What I'm going to talk in next 15 to 20 minutes, which he has asked me to talk on, slowly evolving diabetes in young, particularly the latent autoimmune diabetes in adults, which is what we call it LADA. I don't have any conflict of interest for this particular talk, no financial disclosure, but I'm advisory board member for many of the diabetes care pharma company which are working in India. To overview of LADA, by definition it's an autoimmune diabetes in adults. And above the age of 30 we call it LADA, but those who are getting diabetes below the age of 30, we may call that latent autoimmune diabetes of adults, which is lady, which is in young, with slow progression, so often misdiagnosed as a type 2 diabetes. And this is very, very common in our country, that many of the times these are diagnosed as a type 2 diabetes. Clinically, LADA presents with features which are overlapping between type 1 and type 2. Patient may exhibit symptoms which are increased thirst, frequent urination at the time of diagnosis itself with a unexplained weight loss, like typical of type 1 or insulin deficiency. But diagnosis is often challenging due to its slow progression and the age of onset. Autoimmune destruction of pancreatic beta cell is the primary pathophysiology for it. That's all we can call it slow growing type 1. It's a gradual decline in insulin secretion and they have autoantibody positive. But insulin independence at the time of diagnosis. Many of these patients may not require insulin, or they may not be given insulin for first 6 months. They not require at the time or at the time of diagnosis, maybe up to 6 months. Will we call it is just late onset type 1 diabetes? This is what there is no universal agreement for LADA classification, neither for diagnosis, not for its management. It is slowly evolving immune mediated diabetes, and it's classified as a type of hybrid forms of diabetes in the classification of diabetes in 2019 by World Health Organization. However, it has also been classified as a subtype of type 1 diabetes because of its autoimmune destruction of islet beta cell according to diagnosis and classification of diabetes by American Diabetes Association in 2022. The risk factors are again genetic predisposition and environmental triggers. Most of the time in India, it is only the GAD autoantibodies done, like in previous case also. We don't do the other autoantibodies like islet cell antibody, autoantibodies against insulin, which is IA2, insulinoma associated 2 autoantibodies, which is IA2A, or association of zinc transporter 8 autoantibody, which is T8A, which are not done routinely in our conditions, maybe because of the cost. In compared to type 1, the LADA, the destruction of insulin producing cell by self-reactive T lymphocytes, proceeds a slower speed and more rapidly. Although questioned by some authors, the criteria for which diagnosis usually rest were proposed by Immunologist Diabetes Society in 2005, and recently they have concluded their meeting in Belgium that onset of age greater than 30 years, islet autoantibody is a marker of autoimmune process, and insulin independence for at least 6 months after diagnosis. So these are the 3 cardinal features for the diagnosis. They share same genetic susceptibility and clinical phenotype, more with type 1, but they have some type 2, suggesting a continuum between these 2 extremes. Now if you see the natural history, the type 1 will be very fast progressing, while LADA patients, they normally very slow progressive over a period of time, and in sometimes they have different LADA patients may present also differently. They are obese LADA also, and they may present like a typical type 2 diabetes, even their C-peptide is not low, only thing they will have autoantibody positivity. The epidemiology, it varies globally. Higher rates in European population, as we know that more autoimmune type 1 diabetes are there, but we don't have any data from India. The prevalence LADA varies according to the studies, geographical location, different parts of the world. 3 to 12% of all patients with diabetes with higher rates in Nordic countries and lower rates in Asian and African countries. So we don't have even cross-sectional data from India too. In UKPDS study, the prevalence of antibody against pancreatic islet, which is GAD autoantibody, was 12% of all patients. I mean, very high in compared to that in all type 2 diabetic patients. The prevalence of patient diagnosed with diabetes before the age of 35, this could reach to 34. So it means young diabetes, those patients to whom you are seeing below the age of 35 or 40, you may see up to 1/3 of them may have autoantibody positive, and they may have LADA. In Spain, the prevalence of anti-GAD antibody in type 2 diabetes population, southern Spain, they have done across all population. I mean, maybe elderly or maybe young diabetes, it was 3.7%. Now, key parameters, the difference is the age onset normally in adulthood, in type 2 diabetes. But now as we are seeing type 2 diabetes also in younger and younger population. In India also, one paper which was published in case report, the youngest type 2 11-year-old from South India. The type 1 is most commonly occurs in children, but that's not again true. Below the age of 19, we get every year 24,000 young adults or below the age of 19 who are developing type 1 diabetes in our country, but almost similar number of people, around 20,000 adult type 1 diabetes also in our country, which is every year is in added. This is what IDF data. The BMI is normally with type 2 diabetes, they are obese or overweight, while LADA and patient with type 1 diabetes, normally they are underweight or normal weight. So this is again a difference, but again, as I told you, there is a typical one more class is obese LADA 2. HLA susceptibilities is LADA also have compared with type 1 diabetes, so both of them have increased. Number of islet cell autoantibodies are more with type 1 and LADA. C peptides level are low. Now it is very, very low. Below the 0.5 will be more typical of type 1 diabetes, while it will be low like not high, which is there or normal in type 2 diabetic patient. Insulin independence, normally they are not for first 6 months, and some of them who are misdiagnosed as type 2 diabetes, doctors continue to treat them with oral anti-diabetic agents maybe for few more years also. But normally type 2 diabetic patients may not require insulin for first 5 years or even sometimes 10 years too. If we just see the change in profile, these the patients with LADA, they have beta cell dysfunction, which is deteriorating over a period of time, and they have higher insulin resistance also in some of the patients, but normally not like what we see typically of type 2 diabetes. Now this we all know about the honeymoon phase in type 1 diabetes, and I'm sure all of us know about the honeymoon phase of type 1 diabetes. I need not to talk more about it, but why I have taken this slide in honeymoon type 1 diabetes, because there is a one paper that can be called LADA and type 1 difference is, it is like between a honeymoon and holiday. So I mean the patients who are LADA, actually they are not having a honeymoon, they are actually taking, it's like a holidays for a pretty long period of time. They are insulin independent, and while in a honeymoon phase they are diagnosed, for after some time they are discontinued with the insulin therapy, or maybe because of their very good control the requirement goes very less, and this may be more or less maybe for few years or few months only, but some patients maybe for more years. In LADA they are typically for many years, even the autoantibody positivity, they may not require even insulin too. Now how to screen, to whom we should screen, there is a calculation also, like we have calculation for other systems. So there is a test for autoantibodies in atypical diabetic cases. Whenever you find below the age of 30, 35, 40, anyone, any atypical presentation get autoantibody. Recently published study suggests the relevance of applying clinical scores that make LADA diagnosis more likely. This is in 2016. One paper was published with clinical tool. The age is less than 50. BMI less than 25, symptomatic hyperglycemia. So now this is very important. Whenever you see any patient might have come to you as a secondary or tertiary consultation. Maybe after 2 or 3 consultants he had seen in between, and 5 or 10 years after that. How patient was diagnosed, that's very important. So before 5 years, what was the reason of diagnosis? Before 10 years, how patient was diagnosed? We all know the clinical medicine, and we do the ODP, like origin, duration and progress of the disease. But while treating diabetes, we completely forget the origin, duration, progress of the disease, that before 10 years how patient was diagnosed, and what was then last 10 years how it's progressed the disease. That's very, very important. Assess C peptide level for residual beta cell function. I don't know why in the previous case C peptide was not done. It is very cost effective, and in India it's hardly 400 rupees or 500 rupees which is costing. Monitor glucose variability. So more the glucose variability, the chances that C peptide level or residual beta cell function is very low. Reduce features of metabolic syndrome. Now that's very common with autoantibody or positive or LADA, because they have less obesity, less triglycerides. So this previous patient was also not having high triglyceride. Even there is a dyslipidemia, which is not very typical of Indian phenotype, because Indian phenotype will have low HDL and high triglyceride, which is more of a metabolic profile. If you find that type of thing, then think of more of insulin resistance diabetes, more of a type 2 diabetes with increased other autoimmune disorders. So either they have very strong family history of other autoimmune disease, or they have history of autoimmunity too. There is a significant link between gut microbiota and autoimmune targeting of islet beta cells. Now we know that gut dysbiosis and gut microbiota correlation with not only with type 2 diabetes, with obesity, with other autoimmune diseases too. And in LADA also we found that there are data to suggest that LADA have a decrease in short chain fatty acid producing bacteria. This SCFA producing bacteria can regulate intestinal hormones, increase insulin sensitivity and attenuate islet beta cell destruction. Remarkably, this suggests that gut dysbiosis in patients with autoimmune diabetes may contribute to onset and progression of disease, but this requires further high quality evidence to confirm it. This is one paper which was recently published in 2023 talking about more of the gut dysbiosis along with type 1 diabetes or other increase in autoimmune features in patients with LADA. What's the treatment strategy that should be there for people who are slow growing type 1 diabetes or slowly growing diabetes in a young adults? There is no uniform drug administration strategy has been formed for the treatment of LADA. Meta-analysis studies had shown it is residual beta cell function that's indicated to assess effectiveness of LADA treatment design. Again, it will go with the exercise and treatment, diet, but other pharmacological agents other oral agents can be started or not. And there are multiple papers of using even in patients with autoimmune diabetes, GLP-1, SGLT2, DPP4, all other molecules, but role of sulfonylurea is a double query. Early initiation of insulin therapy is the right way to start these patients because they have some residual beta cell function, but still they need insulin therapy for a better control. Transition to insulin therapy is required as soon as you find that beta cell function is declining. OHA, these are the different papers, but SGLT2 inhibitor can be used more with a obese LADA patients, but there you have to be wary of they may go in diabetic ketoacidosis because the residual beta cell function is poor. On the other hand, the sulfonylurea is effective in early course of the diabetes, but as they are autoantibody positive, it means they have inflammation in the beta cells and the risk of hypoglycemia is more in compared to the patients, and they will also fail. We know that in our second year pharmacology department, we were primary OHA failure, which was primary sulfonylurea failure, that after 6 months they are no more effective. These are the patients actually either severe insulin deficient diabetes or patients of LADA. Metformin can be used with the patients who are obese or insulin resistance or a double diabetes with DPP4 inhibitor and GLP analogs have also shown some benefits, and for these all there are multiple papers to show different OHA or using GLP-1 in people with LADA or obese LADA. Role of early insulin therapy is very high, that's preserve beta cell function. If you start early, it is not only preserving beta cell function, but it also glycemic variability significantly decrease, and they have already some beta cell function is there, so they can be controlled with a small dose of insulin too. That prevents long-term glucotoxicity and improves long-term outcome too. The challenges are misdiagnosis, delayed treatment, limited awareness amongst clinicians, lack of standardized treatment guidelines, and there may be latent proportion of adult onset autoimmune diabetes, mellitus, which are completely misclassified as a type 2 diabetes. Let me talk about this important clinical case, and unluckily she is a doctor also. She is a 43-year-old female, duration of diabetes since 12 years. So when she developed diabetes, she was at the age of 31. Her HbA1c is current 9.2 with lot of hypoglycemia in between too. She had been started with a 30/70 insulin, premix insulin, after 2 years of uncontrolled diabetes. So at the age of 33, before that she was given all other medication. At the age of 33, she was started with a premix insulin, presented with mild pedal edema, with albuminuria and creatine of 1.6 with diabetic retinopathy. Now where the mistake is being done? She was started with premix insulin before 10 years. Currently also she is on premix insulin with 30 and 25 with glimepiride and metformin. Still the OHA is going on with vildagliptin. Gliptin is also going on with telmisartan and amlodipine. This is what the current situation. So the mistake which has been done, that patient was not asked that history, how she was presented at the age of 31. She was presented at the age of 31 with an insulin deficiency, like a patient with typical of polyuria, polydipsia. She had unintentional weight loss of more than 6 kg at that time. She was started with first sulfonylurea with a low dose. She got controlled, so they thought of that typical type 2 diabetic patient. Then she gained the weight. She was started on a metformin. Then over a period of time, the sulfonylurea dose increased. Then for next 2 years, her sugar remained uncontrolled. She put on a premix insulin. Nobody has done her C-peptide level. Started on a premix insulin. Constantly her dose was increasing and decreasing. In between, she had developed multiple time hypo and hyperglycemia. Never in premix insulin. Sugar was well controlled. In next 10 years, she had developed all the complications. She is to be treated like a type 1 diabetes if her beta cell function or that has completely deteriorates, or you get C-peptide level which is low. But sometimes it is getting again confused because of severe insulin deficient diabetes. We know that one cluster of type 2 diabetes is a severe insulin deficient diabetes, which is SID, which is not autoimmune positive. They have also low C-peptide, not like a very low C-peptide like a type 1, but they also present with a insulin deficiency type of diabetes. They present with the typical symptoms of polyuria, polydipsia. We also get, if they are autoantibody, they are autoantibody negative. So the only difference may be between SID and LADA. The presentation may be same, but they are autoantibody negative, and both of these patients may require early insulin initiation. Only difference may sometimes with the SID patients, they may have, you can think of giving them sulfonylurea, only low dose, but there is again the risk of hypoglycemia and the role of OH is more, while in the patient with LADA that is less, unless they are obese LADA. The differentiation is only by the way of autoimmunity. Now the patients who present to us after 10-12 years of diabetes, maybe a SID variety or maybe a patients of LADA, even if you do the autoantibody, sometime it may be negative because over a period of time, the autoantibody positivity also gets diluted, and that may be the one reason. So get autoantibody at the time of diagnosis or maybe within 6 months or 1 year or 2 years in early course of this, and get the C-peptide, and follow-up C-peptide will also guide you where the beta cell function. So that, and family history of autoimmune disease, and the history of autoimmune disease in person is also very, very common with the LADA patient. So prognosis is slower progression in compared to type 1 diabetes. They have variable insulin dependency timeline. So sometimes we start with once in a day, then may require basal plus, basal bolus, emphasis on a long-term management, which is very important. The recent advances is there. Role of immunotherapy can be given to the patients who are autoantibody positive, may be presenting in adult life, like type 1 diabetes, novel biomarkers for early detection, which may be in a future, and a very, very personalized treatment algorithm there cannot be, because that depends on how much beta cell function they have, how they have presented. That will decide their precisely treatment. And even if you have to start them like you are treating type 1 diabetes for advanced therapy, for continuous glucose monitoring, or even putting them on insulin pump too. The factors which are affecting beta cell protection and therapy, you evaluate all different anti-hypoglycemic agent, immune intervention, and discuss the opportunity and challenges of LADA treatment in perspective of islet beta cell function protector. The key takeaway, LADA is a distinct form of diabetes that necessitates accurate diagnosis and a very tailored treatment approach, and that's very important. Early diagnosis is essential for a very effective management, because it's once in a lifetime you have to diagnose someone, and then what you have to make the plan for lifelong, that how patient is to be treated. If preserving beta cell function remains a primary goal, whatever amount of beta cell which you can preserve in that patient, that's the reason the use of sulfonylurea with a double query, it may get control, but it will fastly deteriorate the beta cell, and that's the reason you don't use it and preserve that beta cell function. That will really help this patient for a better glycemic control, because glycemic variability will be less if they preserve their beta cell function. Recognizing its unique characteristic enables healthcare providers to implement appropriate therapeutic strategy, potentially preserving pancreatic function and improving patient outcome. There are multiple references. I have taken few references from which the slides has been done. With this, I once again thank you.
Type 1 diabetes. This will be my outline, just to give you a global perspective on how difficult and how the prevalence of type 1 is growing. And then I'll talk about a little bit of regional, particularly concentrating on Indian scenario to compare it with Sri Lanka. And then I'll talk to you about what we've done. So ladies and gentlemen, type 1 diabetes used to be a rare disease. When I met a professor of pediatrics back in Colombo last week, he said he used to have handful of patients in his clinics. And now currently the pediatric clinic is overflowing with patients. And that's the worldwide scenario where we see lower prevalence, like in the southern parts of the globe. We used to say that diabetes type 1 was fortunately low, but it's rising. Along with the rising prevalence, we see higher mortality. And you've seen cases already on how difficult it is to treat these patients, and to achieve proper control is very difficult. And in resource-poor settings, years are lost of patients' life. On average, at diagnosis, 35 years are lost is the estimation. Thankfully, few interventions, simple interventions, like providing a glucometer and insulin to kids restores about 25 years of their life. And diagnosing type 1 diabetes timely and starting treatments adds another 3 years. Pump therapy adds another 5 years, but we are far away from providing it at national level yet. But if you look at about what I was saying, can be seen in the IDF Atlas's estimate of mortality, and what the orange ones show that the mortality occurs at ages as young as 25, as opposed to the northern hemisphere, where the treatments are more developed and investigation systems are more developed, where the lifespan could be as high as 70 years for type 1. So India and Sri Lanka are still in the lower life expectancy range. And you can also see from this plot where the deaths globally are 182,000, that's the estimate. And you can see that our region tops the mortality rates. And most of that will come from India. So globally, you can also see that although we think of it as a pediatric disorder occurring in less than 15 years of age, the peak age being 15.4 in most countries, the patient number-wise or prevalence-wise, you will see most type 1s in the older patients, like what Banshi had just shown. And if you look at the global and the regional perspective, you can see that 17% of the patients with type 1 live in the States, and India is globally number 2, followed by Brazil and China, which closely follow behind. And Sri Lanka, we have, from the IDF Atlas, we have an estimate of 14,000 patients, because our country's population is small. It's as big as Chennai in population, and therefore we have a small number, and I will show you our experiences from that. So even in India, you can see that most patients are estimated to occur in the mid-range, the 21 to 60 year group, and similarly in Sri Lanka. And how the IDF Atlas calculated is shown down there, with the estimated incidence of 3 per 100,000 in under 15 years. The estimated case load is supposed to be 14,000. So one way to look at overall care pathways and how well we do is to do diabetes registries nationally. It's challenging. There are some global examples of how well that had been done. For example, WHO had launched this Diamond project. There is this Eurodiab study from which we learn a lot from that data. And US has a search database which also identifies that. In our region, national databases are rare and are more complex and difficult, but there is an Indian initiative where the ICMR database of type 1. I'm not sure how much we have, but we have seen the data from that. eDiaCare is a system that's established in Malaysia. So we have a dearth of national registries from the region, partly because it's technically challenging. Back in Sri Lanka, we had a national diabetes insulin bank, from which a single center bank was established way back in the 1970s, so we had a limited registry. What I want to talk to you about in my next 10 minutes or so is to show how we've done with a national registry. So 5 years ago, we launched this young onset diabetes Sri Lanka pathway, DYOD, which is, as you can see, covers most of the parts of the country in specialized centers. So we hoped at that time to capture most of our patients who had diabetes onset less than 25 years. So whenever you diagnose a patient less than 25 years with diabetes, you enter in the database. 3 pediatric centers have their own database, so they have about 1,000 patients in them. They are not included in this analysis, but the rest of the patients I will show you data from. So this was set up with ethical regulatory commission's approval from one university, and it's a centralized database with anonymized data that can be used to look at. So that's how it appears. You can log in with security credentials, and it's set up with anonymized data. And as you can see, the basic database of type 1 registry can be found with classification that is clinically given. And the option to diagnose type 1 are twofold. You can either have a clinically diagnosed type 1 diabetes. For example, a child comes with diabetic ketoacidosis and is treated with insulin, has typical features, then the clinician will usually enter as a clinically type 1 diabetes. If they have GAD antibodies, is the usual antibody that we do, then they will put it as confirmed type 1 diabetes. So we'll have about 50-50 choice of those patients, because half of the patients in the database will have antibody positivity and the rest will have. So the data that we had extracted was published last December. This was our 3rd publication, I think, analyzing what we've seen. So far, we have 3,157 patients in the registry. If you remember, we had estimates of 14,000, but we have, I think we have not got 1,000 pediatric patients in this from those 3 centers that I described, and we probably are missing another 1,000 patients. So we are down to about 5,000 to 6,000 is our rough estimate of how many patients there are with young onset diabetes. As you can see, little over 50% in that group have type 1 diabetes or are classified and diagnosed as type 1. Then we have type 2 diabetes in about 1,000 in this age group cohort of less than 25 years. And then we have other diabetes. So GDM is not included in this, so that will not be counted here. We don't record GDM in this database unless they have ongoing diabetes. So we had the diagnosis of, among the others, we have interestingly had LADA in about 21 patients, syndromic, which usually was Wolfram's, 1 patient with Cushing's, there were 1 or 2 with acromegaly, and so on. There were a few Prader-Willi syndrome patients, and so on. So these syndromic patients were those who had other diagnoses of diabetes, other endocrine or other disease syndromes that led to diabetes. Then we had pancreatic disease. Few had pancreatic, 1 or 2 had pancreatic cancer, few had pancreatitis, few had pancreatic surgery, and so on. Pancreatic would also include sometimes the thalassemia is a big problem in Sri Lanka, as you know. Some of those would be thalassemia, and some of those thalassemia is classified as syndromic. I haven't extracted it as it is, but this is the way the clinician has classified. But those 2 will include thalassemia patients as well. We had drug-induced. 1 patient had a KT, and few had other transplants, thalassemia transplant and so on, and they were on steroid treatment. They were on 4 autoimmune conditions, they were on steroids, so those were the drug-induced cases. And then we had a fairly big cohort of MODY patients who had been genetically diagnosed. Sorry, just going back. So one of the things that we've been discussing in this conference is the heterogeneity of the diabetes and how BMI sometimes foretells the diagnosis. So we've been discussing a lot about that. So to help think I've classified the diagnosis based on the BMI. So you can see the blue ones are the ones with the BMI less than 18, and the green ones are the BMI more than 23, and in between BMI 18 to 23 is the red ones. So you can see that the type 1D is more common in about 80% of those who had BMI lower than 18 were classified as type 1 in the database. And similarly, in the BMI more than 23, more than 50%, about 56% of those patients had type 2D. So you had these variants. We had one FCPD, which was in the middle range, the 18 to 23 group. KPD means ketosis-prone diabetes, which was like spread across the 3 BMIs. So this is the 50-odd percentage of patients. About 57% of patients in the database had a diagnosis of type 1 diabetes. They had a mean age of onset in Sri Lanka of 14.1, and the mean BMI was 21. And not surprisingly, they had a mean A1C at entry into the database of 10.3, which is horrible standards of care, as you can see. So this is one of the reasons why we say the mortality tends to be higher along with morbidity for this region. So if you look at the treatment, you can see that at the onset, they were not all on basal bolus therapy, but currently with the initiatives that the database takes, about 50% are on a basal bolus regime, still about 35% are on a twice daily premixed regime. There was small percentage, 14% on a premixed with a lunchtime soluble insulin regime. There were small numbers on oral insulin. I have said incomplete information for the bottom clause, where there are about 173 patients in which only oral drugs were entered. So we have to clarify the data as to whether these were patients who had latent onset autoimmunity, had originally required insulin with ketosis, and now are in either honeymoon phase or are now in temporary remission without requiring insulin. I have to cross-check also with A1C to see whether they are on the right treatment, and we need to clarify that. It could also mean that there is other forms of diabetes that we try to classify as type 1, but that's why I have separately classified them. So morbidity-wise, you can see that about 8% had morbidity. Primary morbidity was microalbuminuria. As I said, we had one patient out of here who had already had a KT. We don't do combined operations yet, pancreatic and kidney transplant yet. Retinopathy, neuropathy, and diabetic foot were also common in those who were under 25 years of age. These are not end-of-age children, adults. These are young adults who are less than 25 years of age. So having this kind of morbidity is pretty significant for their life. So ADA and other organizations recommend a comprehensive care pathway for type 1 diabetes, obviously to prevent complications and also to give them extra years of life. Those include proper assessment, giving insulin, educating them to take care of their insulin doses, knowing about illness and how to change the dosing, and also what to eat, what not to eat, kind of a pathway. And pumps and glucose monitoring will go along with that to improve care. As I said earlier, we went for the best buys for this program. So timely diagnosis adds 3 years, and insulin and providing them strips adds 25 years. So we went on those two and ignored pumps and CGMs for the moment because of their cost. So Life for a Child, we worked with Life for a Child, which is Diabetes Australia's NGO or charity arm. I must thank Professor Nihal Thomas for putting us in touch with them about 10 years ago, and we started this program 4 years ago, where they provide us with insulin for all these children and 4 glucometers. So those are what the children receive. They receive basal bolus therapy, and the project itself started our own nationalized carb counting book and tools, and we are working on an app right now, and the glucometers and strips are provided along with pens, lancets, etc. So roughly about 17,000 rupees worth of donations are given to each child every month. And in addition, they are provided with training camps. You can see some calorie counting activities, etc. So what we've done and seen over the last 3 years since we've started, the registry was started 5 years ago, and then we've started implementing these little changes, you know, the best buys, the provision of basal bolus therapy as much as possible, providing glucometer changes their lifestyle and the way they control themselves. And you can see the way HbA1c has dropped in this group. I must tell you, the type 2 average A1C for Sri Lanka is 9.1. So yeah, we've done better than that for these children. We don't have to be satisfied with that, but you can see that the little things we do, like just the provision of insulin to children and providing glucometer, makes a major difference over time. And that also enables capacity, because we capacity build for them to be able to care for themselves and be able to adjust the doses themselves, and that makes a major difference to them.
I'm going to start by showing you a well-known map of the incidence of diabetes throughout the world, and this is from the latest IDF publication. And this shows the expected sort of latitudinal relationship between of the incidence of type 1 diabetes being highest in the northern or most southerly latitudes. So I want to draw your attention to the grey areas in this map, which are where no estimates are made. And you can see a lot of the developing world, the poor world, particularly Africa, are coloured grey. Some of the other countries are blue, which indicates a low incidence. But I'm going to show you some data which suggests that we may be missing an awful lot from what's shown in this map. The problem in Africa and many other countries is we have extremely limited data. Most is from referral clinics. There's very, very little population-based data. We lack good laboratories. Laboratory analyses are difficult, and quality problems are a major problem, or analyses are just not available. Often it's difficult to distinguish type 1 from type 2 diabetes. And one particular problem in Africa is a high frequency of political instability and war. This makes any research extremely difficult. So I'm going to take you to Ethiopia. And if you go to a rural diabetic clinic in northern Ethiopia, your average diabetic patient will look something like this. This chap is a poor peasant farmer on a very low income. He's come to the clinic with 6 months of severe symptoms, weight loss, polyuria, and so on. You measure his blood sugar, it's very high, and he's totally dependent on insulin. And remarkably, in this part of the world, 7 or 8 out of 10 patients are insulin dependent of this type. This is a big problem. Insulin is only intermittently available in Ethiopia. Its cost at the time of this study was about $200 a year, and this is far greater than this chap's annual income. He has great problems in keeping it cold. Glycemic control is impossible because he can't afford a glucometer. And diabetes care is often poor or non-existent. We've been very fortunate to work in Ethiopia, where we have a couple of centres, one particularly in the north, Gonda, and in the south, Jimma, where we have a central diabetes service in a university hospital surrounded by a large rural area. And in these rural areas are a series of peripheral clinics that provide a diabetes service. And in Ethiopia, the Gonda clinic was run by Professor Sahay, who's with us at this meeting, and she's kept a remarkable set of records over 20 years of all the diabetic patients in Gonda. You can see a page from these records which give the age, the location and the type of diabetes. Using these records, we've been able to derive some incidence data in Ethiopia, and this is some of the first population-based incidence data available in Africa. And using the records in Gonda and Jimma, and this is from both the central hospital clinics and the rural health centres, we had a total of 2,280 diabetic patients, and found that about half of these were insulin requiring, 45%. And this gave us an incidence of insulin requiring diabetes of about 2.1 per 100,000 per year, which is low in international terms. If you look at the difference between the insulin requiring and the type 2 diabetes, they're quite dramatically different. Here's our patient, and here's a typical type 2 patient. They're very different in age. You can see that there is some overlap in age, but not very much, that these are much younger, these are older. The insulin requiring patients are astonishingly thin. The rural patients had a mean BMI of 16.7. The type 2s are much tubbier. This is not fat by international terms, but it's fat in Ethiopian terms. And one of the big differences was that the type 1 patients tended to be poor, so they were subsistence farmers or unemployed. The type 2 patients had some source of income. They were either government employees, they had a business, or some other source of income. Using these records, one of the things that came up early was that this is an astonishingly bad disease to have in Africa. And of the patients presenting to Gonda in those 5 years, 1995 to 2000, almost a third had died at the end of the 5 years, at about an age of 32 years. So it's an astonishingly bad disease to have. Now, using the population data and the register, we're able to calculate incidence, and this is where it gets really interesting. You can see this is the age incidence curve for insulin-dependent diabetes, and you can see that it's fairly uncommon in children, but there's a steep rise in the 20s, so reaching a peak in about the mid to late 20s. The other thing to notice is that this is much, much higher in the men than the women. I'll come back to this. Now, this line is the age of 16. If you go to a typical European study, and I'm quoting the work from Sweden, which I think is some of the best work we have. This is this age of 16, and you can see almost all the cases in Sweden. There's a much higher incidence in the children, with much lower rates in adults. So in Africa, we have a very, very different situation of a much older age of presentation. And this is a feature of many other countries. There are about 4 or 5 studies on this at the moment. In South Africa, Ethiopia, Ghana, and 2 studies in South Africa. You can see the peak age of presentation is round about 10 years later than we see in the West. In some studies, there are comparison groups, and you can see here it's much lower in the whites, German control group compared with Ghana, and another further white group in South Africa. One of the other features of working in Gonda is that there are very, very big differences between urban and rural populations. Here's the urban population, and it's a small, out of the total population we studied, about 5 million people, about 300,000 are urban, and these are much, much wealthier than the people in the rural area. You can see most of the people here have shoes. A lot of the people here have bare feet. One of the interesting things that came up here was that there's a very, very much higher incidence in the urban areas than the rural areas, and you can see the incidence in men and women. Again, this male excess being a feature of both urban and rural areas. And if you look at these figures, they're getting on for the figures in Europe and the US. This raises the question of what's happening in these rural areas. Is the incidence just low, or are we missing people? It's quite possible that people with diabetes are being underdiagnosed and dying in the corner of their hut with some other inappropriate diagnosis. Putting all this together, we're getting this sort of pattern of disease in Ethiopia. So if we look at type 2 diabetes, there's a lot in the urban areas in both men and women. It's astonishingly uncommon in the rural areas which are poor. Type 1 diabetes, more in the urban than the rural. But because type 2 diabetes is so uncommon in the rural areas, almost all the cases you see are type 1. Moving on then, what about the role of islet cell autoimmunity? Well, autoantibodies are a surrogate measure, but easy to measure. Most common antibodies against GARDA, but there are a lot of other antibodies, and there are a lot of things that affect the prevalence of antibody. One of the important ones is the time since the age of onset, and these antibody levels decline with the duration of diabetes. And if you took a Western cohort, you find relatively high rates of these antibodies, particularly in children, but continuing high rates in older people. We did this in a sample of 236 new Ethiopian patients, and these were measured within a year of diagnosis. And you can see that the major antibody we see is GARDA. Overall, it's 55%, which is a bit less than the West. It's similar to the West in the children, but rather lower in the adults. And importantly, we saw very, very low rates of other antibodies, and this contrasts with the situation in the West. And this again seems to be a feature of sub-Saharan Africa. There's not much data, and most studies are based on old blood samples where there's a considerable lag between the diagnosis of diabetes and the measurement of antibodies, but most of them suggest that we're seeing low levels of antibody. What about the genetics? Well, there's a vast genetic diversity in Africa. I'm not going to talk very much about this, but just say in Ethiopia, there's a considerable interchange with the Arabian Peninsula and genetic admixture, and that indeed the people in northern Ethiopia speak a Semitic language, Amharic. And doing some genetic analyses, we've shown that the prominent type 1 diabetes risks in European origin populations, these are the HLA alleles, are strongly represented in these Ethiopian diabetics. You can see this one is about twice as high in the GARDA positive diabetics as with the controls, and so on as for this one, and this protective allele is the other way around. And when we went further and calculated a genetic risk score based on an established bank of 19 SNPs of European background, again, these were strongly associated with the disease in Ethiopia. Now, one of the very interesting things about Ethiopia is there's a rather interesting natural experiment going on. Gondar was the home of the Flasher Jews, the black Jews of Africa. And these were having a terrible time during the communist era in Ethiopia in the 1980s. And they were airlifted to Israel, over 100,000 of them in the 1980s, 1990s. And these Ethiopians have been followed up in Israel by Amnon Zum. And what's really interesting is when they move to Israel, the offspring have a pattern of diabetes much more akin to what we see in Europe. And so this is the incidence of childhood diabetes. In Ethiopia, it's very, very low in this, it's under 16-year-olds, particularly low in rural areas, a bit higher in the urban. among the Ethiopian Jews that have been settled in Israel, you see a childhood incidence which is actually much higher than other Israelis, and they seem to be rather susceptible to diabetes. Interestingly, that the age of onset in the offspring seems to depend on the amount of time lived in Israel by the parents born in Ethiopia, and this strongly suggests that we're dealing with something in the environment. Rather the same sort of thing seen from other studies of it. This is studies of Swedish immigrants, and you can see people born in Ethiopia and born in Sweden. They have much higher rates of diabetes. Same for Eritrea, Somalia, and East Africa. So, reigning parties are trying to put this all together. Given the history of Ethiopia, Ethiopia had very severe famines, most lately in 1990 to 1992. And this shows a picture from that famine, and these are catastrophic famines where a lot of people died. There's a high prevalence of nutritional stunting, and surely this suggests that we're dealing with a nutritional etiology for this type of diabetes. And indeed, if you look at the data in the Gonda register and look at the height data and work out the standard deviation scores, and this is done with respect to world standard populations, you can see that everyone has a low SDS height level. The figures here are the percent stunted, and you can see that particularly the males in rural areas are very stunted, and with a high prevalence of overall stunting, which is less than 2 standard deviations of height. When you compare them with controls, and we did a case control study comparing patients and controls, this sort of confirmed the associations with low socioeconomic status, subsistence farming, low levels of education, and markers of poverty. But we found also that many of these people had been treated for childhood malnutrition. They had a low BMI and low fat mass, and stunting and disproportionate skeletal growth, and this was more so in the diabetics than the controls, and more marked in men. So putting this all together, one of the curious things here is the male excess we're seeing, and one explanation of this may be that in Africa the stunting seems to affect male children more than female children, and in Tanzania, Zambia, Malawi, and Nigeria, you can see that this is the asset index, so that those who are poorest have greater prevalence of male stunting in all cases. So if we put this together, what have we got? We've got type 1 diabetes, a disease of poverty. We've got older presentation, we've got a male excess, we've got differing patterns of islet cell antibodies, and evidence of stunting. This is the sort of a diagram of what we think might be going on. That poverty, and particularly rural poverty, is associated with poor nutrition, but probably a lot of other things with poor nutrition, and helminth infections and other things that go with poor nutrition are certainly important. That this will lead to stunting. That we know from animal experiments that it's very likely to impair beta cell growth. But also there's a considerable evidence that poor nutrition can affect immune function. This is almost certainly affecting immune function in our diabetics. There's an interaction with male sex, so that if you're male, you're much more susceptible to the effects of poor nutrition, and that these combined together lead to what we're calling undernutrition modified type 1 diabetes. But in this week we've been arguing as to what this term should be. So I'm going to finish there, and just to say thank you to all the people
in the task of speaking on quality of life in type type 1 diabetes. So we just heard about all the challenges of type 1 diabetes, whether you look at it in Sri Lankan context or the Indian context that Dr. Noel spoke about, and also in the more economically deprived populations where you may find greater challenges in terms of diagnosis and management. So quality of life is significantly influenced and is affected in type 1 diabetes. So if you look at the definitions of how WHO defines quality of life, they define it as a multidimensional concept as individuals' perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards and concerns. So it's the construct that we're looking at is in the context of their cultural and value systems and their goals. And so this is a very important health related outcome, with good quality of life representing the ultimate therapeutic goal in managing all chronic conditions. I mean, whatever we do in terms of the medical management, but if we should be able to provide a good quality of life to people who are having these chronic conditions. And to add to just adding to that, we have this health related quality of life, which could be defined as the physical, psychological and social domains of health, seen as distinct areas that are influenced by a person's experience, beliefs, expectations and perceptions. So health related quality of life is used to measure self-perceived health or disease status, and to understand the distinction between aspects of life related to health. So with these in mind, let us see that the challenges that we see in people with type 1 diabetes is that they have significant effects on it has a significant effect on the mental health of the individual, whether the diagnosis is made in the childhood, adolescence or adulthood, has different concerns. The needs are different at different phases of life, and also the fact that the effect on the quality of life is differently perceived at different time periods. So the schedule and routine of the individual living with type 2 diabetes, along with their families and caregivers, can increase the stress levels to the point of becoming a medical emergency if matters are not managed in timely fashion with care and compassion. So therefore it's important that we give attention to this, and because we see that diabetes can have a negative effect on life and physical well-being by leading to the short-term complications through demands imposed by the intensive therapy that is needed, and also the monitoring that is required, regular monitoring that is required. All these affect the psychological functioning of the individual, and this can also affect the person's interactions with other individuals, and social interactions are influenced, and this also has a impact on the quality of life. And again, you're looking at the long-term stresses associated with the complications that can concern about the complications and the interference with the daily activities. All these have an impact on the quality of life. And if you look at the various studies that have been done to look at quality of life in people with type 1 diabetes, we see that they have lower health related quality of life, lower levels of employment, more sick leaves per year as compared to the general population. And it is also seen that women with type 1 diabetes have a poorer quality of life, higher HbA1c, severe chronic complications and lower education. All these are factors that can actually lead to a poorer quality of life. Apart from these factors which I have just spoken of, the other factors could be the medical aspects, like the severity of glycemia that is there, the presence of complications, occurrence of acute complications or variability in the glucose levels, and recurrent hospital admissions. All these have a significant impact on the quality of life of individuals with type 1 diabetes. And they lead to a significant prevalence of anxiety, depression, leading to eating disorders, and all these can have a significant impact on the life of the individual with type 1 diabetes. So anxiety and depressive symptoms are found to be the two most prevalent mental health conditions in youth with type 1 diabetes. and it is the ADA recommends that we should be screening youth with type 1 diabetes for psychological, psychosocial concerns like depressive symptoms, diabetes distress, and eating disorders. These actually have a bidirectional relationship. The anxiety symptoms are lead to higher HbA1c levels, poorer self-management, coping behaviors, depressive symptoms becoming more common, fear of hypoglycemia becoming more common in those who have anxiety symptoms, and lower blood glucose monitoring frequency. All this has impact on the diabetes management, and similarly, the diabetes itself, poorly controlled diabetes itself can lead to more of anxiety and depressive symptoms. So therefore, there's a bidirectional relationship with diabetes and the mental health disorders. And the other important aspect that has to be looked in, particularly in children with type 1 diabetes, is the effect of the caregiver distress, the parental distress, the parents having significant, they often are distressed because of feeling overwhelmed, sad, or concerned. And studies have shown that 1/3 of parents of youth with type 1 diabetes report severe distress up to 4 years after the diagnosis of type 1 diabetes. So in the initial years, this is much more, and parental stress is believed to result from daily diabetes related tasks, financial problems, the fact that they have additional financial requirements for these children, managing their blood glucose fluctuations, monitoring their control, and the guilt or fear they have of future medical complications. So if parents feel distressed or overburdened, they may prematurely transfer the responsibility of diabetes management to their child, and this very often leads to poorer control. Parental burden is also an important construct for assessment and intervention in children and adolescents with diabetes. Therefore, there are several scales used for assessing the quality of life. I'll just walk you through a few of them. The WHO Quality of Life Questionnaire and the Diabetes Quality of Life Questionnaires are probably the most common instruments that are used. The Quality of Life in Diabetes Questionnaire developed for Indian diabetes, Indians patients with diabetes, also one of them which I'll just take you through. And these lead to better recognition of the impact and importance of timely assessment of the quality of life that is required in managing chronic conditions like diabetes. Now, if you look at the younger children, we have a pediatric quality of life questionnaire, which can be used for young children. For parents and children above 8 years, it can be self-administered, while for younger children who are for 5 to 7 years, that needs to be administered by reading out to the young child. And for those below that age, it's generally done with the parental help. So each item is scored 0 to 4. The scores are transformed to a scale of 0 to 100, and with higher scores indicating a better quality of life. So this is the pediatric questionnaire, pediatric quality of life questionnaire, and the pediatric quality of life questionnaire, which is parallelly done for the caregiver also, or the parents also. And then we have a type 1 diabetes distress scale, which has 28 items, 7 subscales, and total score is with a total score coming to coming up to 100. Designed specifically for type 1 diabetes, it's psychometrically robust and well validated. Respondents are asked to indicate the degree to which each one of these items is currently a problem. 1 not a problem, to 6 which are very serious problem. And it leaves a total diabetes distress score plus 7 subscale scores which are also used to quantify the diabetes distress. So as you can see, this is the diabetes distress score, type 1 diabetes distress score, which is graded from 0 to 6, the 1 not being a problem and 6 being a significant issue. Each of these issues are taken into consideration. Then you have the problem areas in diabetes scoring against a scale, which is validated scale, which is having 20 items, and each one of them marked from 1 to 4, and then totaled up to, then factored to give a score of 100. So total scores of 40 and above indicate severe diabetes distress. So this is again a very commonly used scale that is used to assess problem areas in diabetes. And then we have another score like the Zarit caregiver burden score. Again, I'll not go into details of that, but all these scores are very helpful in assessing the quality of life in diabetes. So this is a Indian validated quality of life in diabetes questionnaire, which was developed by Nagpal et al. And it takes, I mean, on the average, it's been shown that it takes just about 7 or 8 minutes to complete, and hence it can be used during routine physical consultations, physician consultation. It consists of 34 items covering 8 domains. So it's quite a robust scoring, validated scoring scale which can be used, and questions are again marked from 1 to 5. Low scores indicate poor quality of life and higher scores indicate a better quality of life. Maximum score that you have is 170 here. So this looks a little quite a busy this thing, but it has been shown that it can be done 7.8 minutes, as was shown just now in the slide. So this questionnaire is quite a robust questionnaire which can be used. And we also have the Dawn questionnaire, which has 22 validated items, and this was this again higher again scored with higher score 0 to 4, higher scores indicating a greater adverse impact on quality of life. So this is the Dawn score. Now coming to the important factors which are influencing the quality of life. Hypoglycemia is, I think, the most important factor, because hypoglycemia, as we know, is the most important limiting factor for good glycemic control. And the exposure to hypoglycemia, past exposure to hypoglycemia, or just the fear of future episodes are associated with several adverse outcomes, including impaired emotional well-being, sleep quality, work productivity, and driving freedom. So the fear of hypoglycemia also, if they have had a hypoglycemia, that becomes a major issue. And most studies have shown that hypoglycemia is a major factor which has a significant problem. Some studies have shown that hypoglycemia probably is not that important, but this is an important analysis that was done, the USA hypoglycemia analysis, where they showed that hypoglycemia has a significant impact on the quality of life. It also negatively affected the financial situation. Self-treated hypoglycemia was the one, as compared to self-treated versus where there is awareness, absence of awareness to hypoglycemia. Those who had absence of awareness had probably more significant distress as compared to those who could self-treat their hypoglycemia. Coming to therapy areas, when you compare the therapy, those who are on, so this study looked at those who were shifted from basal bolus therapy to a pump, and they found that the quality of life, although the glycemic control improved quite significantly, they couldn't really make a little significant difference in terms of the quality of life, although it was significant at 0.1, using a p-value of 0.1 as a significance. And the main reason was that, if you look at the adjusted multiple logistic regression models of this, from this study, what was seen as the most important factor that increased the total quality of life was lower type 1 related expenses. But when you're looking at a pump, you're increasing the expense. So that becomes a sort of negative effect on the quality of life. Men and those with more years of living with type 1 diabetes had better quality of life, and the method of administration. The quality of life was the main reason to use the insulin pump, but the expense was the main reason to avoid using the pump. And so we should look at reimbursement policies which can provide pumps and thereby reduce this factor of expense, and thereby the improvement in quality of life can be more significant. So in this in a similar study, which was a randomized control trial where patients on basal bolus therapy were randomized to receive a pump versus continuing basal bolus. When they did that, they found that there was a very significant improvement in the quality of life with the use of a automated pump, the HCL, that is the automated hybrid closed loop. led to a significant improvement in the quality of life, and the HCL group became more emotion oriented in stressful situations. They could cope well with stressful situations, and they had much improvement in their quality of life. So showing that this is something which is certainly having an impact, but the cost factor of the pump and usage and all that gets down the benefit that we see. Looking at a few studies from India, we have a study from the Department of Pediatrics and PGMR. They assessed the quality of life in 97 type 1 diabetic children, and they reported that impaired quality of life was seen only in 18% of children with type 1 diabetes. And poor glycemic control and an increased number of hospitalizations were the two most important factors which were contributing to the poor quality of life. Then the overall outcome of children can be improved by improving the quality of life. So this is important, that looking at these factors. Another study using the Dawn quality of life score was done from Haryana, where 46 type 1 diabetics were screened with this questionnaire, and also the WHO 5 well-being index. And what was seen was that low mood was found in 26% of the subjects. Children with recent diagnosis, older age at onset, elevated HbA1c were identified to have higher prevalence of various psychological and cognitive problems. So it is the younger children who tend to adapt better, while the older ones have difficulty in adapting, and those who have poor glycemic control obviously have poorer quality of life. And if you look at another study from All India Institute Delhi, where they looked at 49 children with type 1 diabetes aged 6 to 18 years, assessed by the Dawn Youth Quality of Life Questionnaire and the WHO well-being index. The significant association noted was elevated HbA1c with poorer emotional well-being, higher negative impact on symptoms of disease and future prospects were seen, shorter duration of diabetes with more behavioral issues, lower maternal education was associated with more withdrawn or depressed behaviors and worry about future prospects, and lower socioeconomic status had lower scores on the quality index. So earlier age of onset was associated with fewer behavioral problems, less negative impact on quality of life, higher prevalence of various psychological and cognitive problems were seen in children with recent diagnosis, older age at onset, lower maternal education levels, elevated HbA1c levels, and those belonging to lower socioeconomic status. So this was in summary the results from Indian studies. And if you look at another study from Pune, they looked at the problem areas in diabetes in pediatrics, and they found that the diabetes distress was higher in mothers than children. Higher distress in children was associated with poor metabolic control. So I think most of these studies have shown that poor glycemic control remains an important factor, and illiteracy and financial constraints also have an impact on the quality of life outcomes. Now, looking at what are the interventions to improve the quality of life, if you look at this study, which looked at 3-month therapeutic education given to children along with their parents, led to improvement in the quality of life. Global and dimensional quality of life scores improved in the group that was given this therapeutic education, which had a significant impact. And RCT, looking at all the self-management education, the role of self-management education in terms of having an effect on the quality of life. This RCT included about 17 studies, and what this showed was that 7 studies detected significant impact of the diabetes self-management education on quality of life outcomes in either the participants or the family caregivers, which varied based on the tool they use, but essentially it means that well-structured education initiatives have a significant impact on the quality of life. This is the details from those studies showing that the education was given by community health workers, also by the physicians and nurses themselves, or by the doctors themselves, and all of them showed improvement in the quality of life parameters. Camp-based education also is another another way of imparting this education, and where you have the parents and the family members along with the children, that actually improves the education and improves the parental anxiety and distress, and that has a significant effect on improving the quality of life.
And I'm here to talk about public health program in type 1 diabetes. Firstly, a big thank you to the previous speakers because they have laid the stage to tell us where we stand in terms of management of diabetes type 1 in the subcontinent. And I'll just quote one of the papers. Dr. Noel was talking about the ICMR Young Diabetes Registry. This is Dr. Madhu's center, the UCM. This was published in the last week of October. And what is pretty terrifying is, of a cohort of about 900 odd children, at the end of 6.5 years, 11% are dead. So that's what the situation in a tertiary care hospital in central Delhi is like. So just imagine when we are talking about rest of India, rural India, and poor India. And I would actually like to thank Dr. Madhu for having published this paper because it puts into perspective the need for a public health program. So when we talk about type 1 diabetes and the problems of management, of course, relatively poor country, proportion that's spent on health is less than 2% of GDP. Dr. Rakesh said, the more you know, the better you are. The level of education and awareness, available infrastructure, particularly in the district hospitals and below, and the challenges related to diagnosis and management. One major challenge is most don't even get diagnosed. And of course, the behavioral and psychological issues that Dr. Rakesh spoke about. So when you're talking about a policy document or policy for management of type 1 diabetes, there are several gaps. And that's highlighted there. I'm not going to bore you with all of that. All of you are aware of the policy gaps. And therefore, we need a program and a model of care wherein the medication would be provided, the monitoring would be taken care of, the counseling is done, emergency care is provided, and we of course have to have an electronic database. And those of you who have been part of the national NCD program, if you actually type in Control F and type in type 1 diabetes for the national program in India, type 1 diabetes features twice. One, where you talk about the types of diabetes, and two, back at the end where it refers to that particular statement. So the components of type 1 diabetes care that we thought of in our model that we would create would be that there has to be some mechanism where you have timely diagnosis and referral, basic care pathway which includes glycemic control, blood pressure control, lipid testing, annual eye checkup, foot screening, kidney disease, preconception care, structured diabetes education is very important, and maintenance of registry. And if you create something for a country as big as India, you've got to remember that it has to be simple, it has to be scalable, it has to be replicable, cost effective, and in line with the currently existing national health programs. You can't come up with something exceptionally different. So what we thought of was every district hospital of India, that is there are 734 district hospitals in India, where you have a adult NCD clinic running from Monday to Saturday. At least on paper it's supposed to be running. We found out that it does not run in several of the places. So we've upgraded that infrastructure to once a week type 1 diabetes clinic. So we started with that model in my state, West Bengal. And when we are talking about the level of care that we want to provide, we are not providing the 780G pumps. So we chose from Graham Oogle's paper, I think Noel was talking about Graham Life for a Child, and we chose the yellow bit that we would target for intermediate care for everybody, which would include basal bolus insulin for everyone, 3 to 4 strips a day for everyone, and we would provide the basic anthropometry and all the investigations, including an HPLC based A1C testing, diabetes education, emergency care, and try and reduce the mortality, morbidity, hospitalization, and ketoacidosis, with the aim knowing that the A1Cs will be somewhere around 8-ish. If you can achieve that in an Indian public healthcare setting, I think it will be great. So it's not that we don't know. This entire audience knows better than anybody else how to manage type 1 diabetes, but we are just not doing it. So there's a problem in implementation of what we are doing. So the data that I'm going to show is basically implementation research. So to start off with, we started off in 5 district hospitals in rural areas of West Bengal, away from the city of Kolkata. And the funding that we got was through the program implementation plan. Some of you know that there's something called PIP, which the state government applies to the central government. The central government pays a certain proportion of the money, and the state government pays the rest of the money. It's more or less a 60-40 kind of a split. And that's the logo of our clinic that we've created, Childhood Type 1 Diabetes Clinic, dedicated in district hospital once a week, catering to type 1 kids. And this is the framework that we thought of how we would go about creating. And we've created a document which which my students say, please don't call it an idiot's guide, but something like a dummy's guide of setting up a type 1 diabetes clinic. So those are the things. So first thing that we did was a sensitization program. So from each of these district hospitals, we told the local authorities, please identify a pediatrician and an adult physician, a clinic nurse, a data entry operator, and the non-communicable disease counselor to come to the central sensitization program. So that was a day-long program. And then we went to these clinics for an initial visit. And we had a whole list of checklists. So the first thing that we said was, we want named individuals to run the clinic so that we know who is responsible for what, and so that they just can't run around and say, just like the other national programs, today you do the clinic, next week somebody else does the clinic. Accountability is very, very important. And I'll go through the checklist of things. For example, the human resource, what we need, the physical infrastructure, most of it was already there because you had an adult NCD clinic. You probably needed a smaller blood pressure cuff for the children and things like that. So we made these checklists of what, kind of registries, the books and things like that you need to make, the formats, the IEC material, all of that we kind of thought of. And it had to have a computer, internet facility, a printer, the trained human resources, the equipments, the drugs and consumables. Now, one of the things that we did was we separated out the pharmacy of this type 1 clinic from the rest of the clinic and the hospital, because we had to ensure that stocks didn't run out. And centrally from Kolkata, I could monitor which hospital clinic has what stocks. Because there's difficulty in indenting, procurement. You had to ensure that this was there, even if the rest of the hospital had nothing. And we plagiarized the adult NCD diary into a type 1 diary for our kids. And we created all of this ID card, because the registration was on the basis of where they stayed, from which district they were. They had their Aadhaar number with which we actually tagged them. The diary, the SMBG logbook, letter to the schools, and booklets in local languages and summary formats, because we were very keen that we had real-time data and not fudged data and not incomplete data. So we created a web-based application portal, so we know every visit what is happening to every child in terms of height, weight, BMI, sugar readings, doses of insulin, whether there was a problem with the insulin injection site and things like that. So all of that is there from the patient perspective. Secondly, in terms of it's an electronic prescribing, completeness of data. It will just not let you move on to the next page unless and until you've actually filled in the data. And the stock maintenance. And all of that was coming in, had to be documented. All of that was being dispensed, had to be documented. So we knew exactly what was there in the backup. So supply chain is very, very important if you're running a type 1 diabetes clinic. The on-site, after we knew all of this was in place, we had an on-site training cum orientation program. And what we did was, one of our junior doctors, endocrinologists, was sent to that clinic once a week for 1 year for mentorship. He would not see the patients. He would just sit there and watch what's going on. And every time there is a problem, they would ask him, what do you do in such a situation? Because you can't teach type 1 diabetes just like that. And these are pediatricians and physicians who had previously never treated type 1 diabetes. So therefore it's difficult. So we did that 1 year mentorship for these people. Now next comes community mobilization. Once we knew that this district hospital, the clinic is strong enough, the pediatrics ward is strong enough, the adult emergency ward is strong enough, and the clinic was doing well, we went down the rung in that district. So we've created a module for the ASHA workers, who are the most important people in India in terms of healthcare. Now, the other thing that we are going to roll out is, for adults, there's a CBAC form, the community-based assessment form. All ASHA workers have been given a tab for collecting data for adults. We've created a CBAC form for children so that we know exactly how many children are there, who has diabetes, so that child can be fast-tracked to that clinic from that particular district, and there is a referral care pathway. So this I've already talked about. So this is an example of one of the clinics. And every 3 months, an educational camp. Because we knew the NCD counselor probably also did not know much about type 1 diabetes. So it's a two-way learning process that we've done. And piggybacking on this, we've created 2 other things which we are launching. Number 1, a program called Mighty, Moms of Type 1 Diabetes. So we've created a moms group and a patient support group, because they are the backbone of improving things beyond what the government healthcare system can provide. So I've already talked about, and if you're looking at the framework of care that, so there's number 1, you enroll the patient, number 2, anthropometric examination, management of the disease, screening for complications, laboratory investigations. You would have thought India has a thalassemia program and everybody would have a HPLC machine. My state did not have. So we had to actually buy each of these district hospitals a Biorad D10 machine. The insulin, the consumables, patient education material, monthly monitoring, daycare facilities, emergency care. So we had a blue light ambulance service in case somebody falls ill, in case the district hospital struggles to manage that child, the tagged tertiary care hospital would be informed and the child would be sent there. So this is one more of the centers. So that's the ID card, which is tagged with the Aadhaar number. And this is the anthropometric examination, management, lab facilities that we created, the insulin that we provided, and the lancing devices, the glucometer. So we provided 100 glucometer strips per child per month. And this is some of the educational material, monthly monitoring, we were doing this, daycare facility, timely referral. The 2 other things that we've done is we've created a module for all of the schools where these kids are studying, so that their teachers are educated about type 1 diabetes, and we have now also got a program integrated into the school health program of Government of West Bengal. The final thing that we've managed last month is all education and all fees for children up to class 12 is now free if you have type 1 diabetes. So data keeping I've talked about. So I'll just quickly go and show you some of the data in 1 year for 4 of the centers. So we are looking at kids who come from families where the monthly income is about 7,000 rupees for a family of 4.5, and the cost of therapy per child is 3,500 rupees. So 50% of the family income goes there. 40% and more of these children come from below poverty line. And 70% of these children, their parents have not completed primary education. So that's the battle that we have there. So Dr. Noel said that, even in Sri Lanka, about 40-50% are on basal bolus insulin. That's what we were on when we started. We've now ensured that everybody is on basal bolus insulin. And if you're looking at injection sites, they've improved. About 20% were unhealthy when we started off, and at least 80% plus are now self-injecting. Only the ones who are about less than 5 years of age are taking assistance from the parents. If you're looking at the glycemic parameters at baseline, the A1C was close to 10. It's dropped by about 1%. And if you're looking at the complication rates in these kids, at the end of 1 year, our ketoacidosis is 0, hospitalization is 0, death is 0. And Dr. Rakesh was talking about psychological well-being, and if I just summarize, I'll just show you in terms of the well-being, the family functioning, the social support. That's the summary. All of those parameters that he was talking about in the previous presentation, things have dramatically improved. I was talking about expenditure. So if you look at the direct and indirect expenditure, at the bottom, you can see when we started, they were spending 3,500 rupees a month. That's come down to 416 rupees a month, predominantly because the mother or the father has to bring the child to the clinic, or there's a loss of wages for that particular day. So where are we going from now? So first of all, like I said, we've created a CBAC form for children. The ASHA workers have been trained. The down-the-line sensitization has been done. The MIghty program is being started, and the patient support group has been started. So we started off with 5 clinics. So the central government and the state government has given me permission to launch 10 more district clinics. Of that, we've already launched 3 in the last 1 month. And we conducted a sensitization program for the same. We've published the methodology paper of this particular project. We've published an editorial in Lancet that this should form the basis of a national health program. The state government of West Bengal has awarded this program as the best model for care amongst all specialties for the year. And I had been asked to join the technical expert group for the central government, and a group was created, because when I had approached the central government to say that we need a national health program for type 1 diabetes, I was told that the numbers are too small, so why don't you sell it as an NCD program for children? So that's the committee created, and that's the draft document which is lying in finance for approval, so that all of India will have a district hospital with a type 1 diabetes clinic. I would like to thank everyone, particularly my PhD student Masuma, who is not here today, Graham Ogle for having provided me insights into how to plan and design things. UNICEF has partnered with us now, so we are UNICEF's model of care for India as part of the PEN Plus program that UNICEF has. JDRF, which has now changed its name to Breakthrough Type 1, is part of our program, and JDRF through the W.J. Clinton Foundation is now a partner for the program. I shall stop there for any questions. Thank you very much.
Simultaneous pancreas kidney transplant. So in next 15 minutes, I am going to speak to you briefly on that. So here is the content of my presentation. Maybe some, I don't think any surgeon is out here, but there is some part of the surgery is also involved in this. So we know that type 1 diabetes is one of the most difficult condition to manage in pediatric age group. And I can say maybe for endocrinologists, Cushing's disease, then type 1 diabetes, they are almost same. Type 1 diabetes is young and Cushing is an adult, and this therapeutic armamentarium for the type 1 diabetes is extended significantly from diet, exercise, insulin twice a day, MSI to artificial pancreas, and so on, and the islet cell transplantation, and then coming to the simultaneous pancreas and kidney transplant. So pancreatic transplantation is of multiple type. Maybe the simultaneous pancreas and kidney transplant, that is the most commonly done in 80% of the individuals. Pancreas after kidney transplant is then around 10% of the population. Pancreas transplant alone, which is indicated in the very unusual situations like diabetes is very brittle and the hypoglycemic unawareness is very severe, where you can go for the pancreas transplant alone also. SPK has multiple advantages as compared to the kidney transplant alone, the pancreas transplant alone, because one is, it is very easy to monitor when you are doing the SPK, because sometimes the pancreas transplant alone is difficult to monitor and subtle finding is there, and maybe by that time this graft rejection is there. So let's see what are the indications for the SPK in type 1 diabetes. So any individual using ESRD or patient on insulin, MSI with C-peptide less than 2 nanogram per ml, or some of the individuals, those are not having classical ESRD, but still if they are having brittle diabetes or episodes of hypoglycemic unawareness is there, we can plan for the pancreas transplant. Though currently the type 1 diabetes is a major people, those are undergoing the SPK, but some of the type 2 diabetes is also undergoing, and in our cohort also, out of this 54 patients, 3 patients underwent type 2 diabetes underwent the SPK, and the results were very good. So these are the indications for SPK in type 2 diabetes age less than 60 years. BMI should be less than 30 kg preferably, because if there is severe insulin resistance, the insulin pancreas transplant may not work that efficiently. And the presence of complications, those are hyperlabile diabetes, can also undergo this SPK in type 2. So when we plan SPK, what are the major contraindications where SPK cannot be possible? So these are certain absolute contraindication. These are not new. We all know that if patient is having severe cardiovascular mortality, morbidity, then it is not good. Or the recurrent myocardial infarction, maybe active sepsis, active peptic ulcer disease, or patient is not willing to take the treatment properly because immunosuppression is the very, very important one. And these are some of the relative contraindications for the SPK that requiring very high amount of insulin, or these patient's BMI is high, age is more than 60 years. Again the same, because if you are not able to say manage because of the chronic complication, then it is difficult. So what is the history of simultaneous pancreas kidney transplant? So it is started first in 1966 in the University of Minnesota. Very few patients were there, and then subsequently the immunosuppressions came into the picture, and that actually improved the outcome with the cyclosporine, then the tacrolimus, and now the tacrolimus and the steroid based therapy is the main agents used for the as immunosuppression for the SPK. 2000 and till 2005 that is rapidly increasing, but in last 5 years because of the COVID there is decrease in the number of the SPK. So how to evaluate a patient of SPK if you are sent to us? That is a routine biochemistry which is required, and as I mentioned, you have to assess carefully the cardiac status, because if the cardiac status is not good, outcome may not be good. Then another very important screening test is Doppler of the iliac vessels. The reason is that the iliac vessels is site where the pancreas is transplanted as well as the kidney is transplanted. So Doppler of the iliac vessels is very important, and I was talking to some of our surgeons, they are telling this arteries of this type 1 diabetes long duration is severely calcified. If those are calcified, then it is very difficult to transplant. So that is very important one. And of course the C-peptide, insulin, HIV is one important one. So these are there. So when you take then most of these transplant is brain dead patients. So when you get in a pancreas, so what are the donor characteristics they can be difficult or they are not eligible for the transplant is that HIV positivity or other viral markers positivity, or patient is alcohol independence. In that case, pancreas, quality of pancreas may not be good, and that is very thoroughly evaluated before putting the kidney SPK or this pancreas. So how to prepare before SPK? So insulin regime is very important, and pre-operative plasma glucose monitoring is very crucial. So because of the stress and corticosteroids contribute for the hyperglycemia of these patients on the insulin infusion, and close monitoring of glucose is required, because many times when this clamp is not open, patient is started developing hypoglycemia because pancreas start functioning or secreting the insulin. They require the good thromboprophylaxis in form of the intraoperative IV heparin or the post-operative heparin subcutaneously, and they all require maintenance of the aspirin from 80 to 325 milligram per day, standard one. And also given the antibiotic prophylaxis, meropenem is given, capsofungin for antifungal, and many of patients require re-exploration actually, and during the re-exploration we have to cover more extensively as compared to the previous one. And then immunosuppression of this maintenance and the induction. So induction immunosuppression is by lymphocyte depleting agents or by the non-depleting agents are used. And the maintenance immunosuppression, as I mentioned, tacrolimus, mycophenolate mofetil, and the steroid is avoided in our initial workup, but that we found that it is difficult to maintain without steroid. So our patient again switched out to steroid for the maintenance immunosuppression. Now coming to the surgery part, so donor surgery, basically in donor surgery you remove the 3 organs, pancreas and spleen, with the C part of the duodenum is removed. So here is the picture of this, how this organ complex is removed, and then spleen is separated, and some more surgery is done in the pancreas. And after removing the pancreas is assessed on the bench, that what is the quality of the pancreas, weight is estimated, and the estimation of the fat is by palpating by the, and assess. If the pancreas is of not good quality, it is not usually transplanted because it's not going to work. For such patients, the pancreas can be used for the islet cell transplantation if it is not going for the pancreas transplantation. And this is the picture that C part of the duodenum is there, you see here, and there is the arterial graft in the V shape from the SMA and splenic artery, and there is the pancreas in the portal vein. So these three vessels are kept in place for the what you call transplantation. So what is the recipient surgery? A midline vertical incision is made, and the graft kidney is transplanted in the left iliac fossa and pancreas in the right iliac fossa. And the arterial supplied by the common iliac artery. That's why I was mentioning that iliac artery should be, Doppler should be there. And the portal vein is actually connected the distal inferior vena cava and the right common iliac vein. So immediate post-op monitoring is required for the blood glucose, of course, and for amylase and lipase is very important. That will give you indication this graft is working or not working. Serum insulin C-peptide is measured, and the insulin will be very high, very high. The reason is that here is hepatic bypass is there because insulin is directly going to the circulation. So it is not that the insulin is very high, meaning by that it is destroyed pancreas. No, it is certainly will be high because there is hepatic bypass. And the monitoring of kidney in SPK is by urine output, urea and creatinine, and the vascularity of renal vessels is very important. Indeed, every day there is a color Doppler is done for the renal vessels. Long-term monitoring is not that difficult as standard in the type 1 diabetes, renal kidney functions, HbA1c, then the once in 3 months microalbuminuria, once in a year for these chronic complications. So medical management of SPK is mainly related to the immunosuppression because patient is now dialysis free, patient is now insulin free, so not requiring any insulin, but same time we have to closely monitor this immunosuppressant levels. That is very, very important one. So these are given usually tacrolimus, mycophenolate mofetil and the Visolon. So overview of the post-surgical complications are the very frequent in initial stage in our cohort also because significant number of patients are required re-exploration within few days because of this some or other problems. And the post-surgical complications are common like infection, rejection, graft pancreatitis is not uncommon, and donor-derived sepsis because this is the problem here when you get a brain death patient because patient's relatives take time to decide, and we know all that there's a very emotional issue. So that by that time patient is in hospital, they develop some type of sepsis. So it is another problem. And of course the post-operative fluid collection and the metabolic abnormalities are also there. So infection is most common, and among them also the bacterial infection is very common, and mortality due to infection is almost 1/4 of the patients. So we have to take care of very good sepsis care, and the metabolic complications for we have to monitor for hyperglycemia, hyperlipidemia and the insulin resistance, etc. So here is the chart which is showing that in immediate post-op period or the long-term follow-up how to monitor that this patient is having the cell-mediated problem or autoimmune mediated problem is there. We have to manage accordingly, and the most of the time manage with the steroid, and the steroid anti-thymocyte globulins is used. So outcome is usually very good, and glycemic control improves significantly. As far as I know, that is the best technique which is having the glycemic control. Almost 95%, 97% time insulin is the time in the range. So that's best, and hypoglycemia is very, very rare. So it is almost kind of cure for the type 1 diabetes. Diabetic retinopathy improves in significant percent of patient after the transplant. And similarly, neuropathy and nephropathy. Obviously, nephropathy is already improved because patient is not requiring dialysis, the kidney is normal. As well as there is not much data is available of the macrovascular complication, what happens to them. But these are not very high maybe because at presentation these are the excluded before subjecting the patient for the SPK. Quality of life, Dr. Rakesh was talking, I think this is the best quality of life possible with the SPK except the immunosuppression, no injection. But we should not be happy for this type of quality of life because you are requiring 2 organ transplant. So in briefly, I'll discuss in few slides what is experience at PGI Chandigarh for this, that. So you see recipients demography. So recipient age is 29 years, meaning by that our mean survival is somewhere 30 years or 35 years of the type 1 diabetes. So that is very, very risky. And the donors are between 25 to 30 years. Most of the patients are because of the roadside accident, they are developing the brain death. So that is another issue. And you can see the range 2 to 49 years. So the youngest kidney or pancreas we received from a donor is also 2 years of age only, and that is functioning very well in that also. So you can see that it was started in 2014 at PGI, and now it is 2024. So far we have done these 54 transplant in last, say, 10 years. And maybe probably this is the outcome of this SPK in our cohort is that, so number you can see approximately 54. Mean creatinine is absolutely normal. Graft rejection in initial 5 years, it was very high. 11 of the 6, there was a graft rejection. In the second 5 years, 2 out of 13. And in last 5 years, it is 1 out of the 32. So that maybe over a period of time, we learned this technique and can do it better. Hospital stay reduced from 44 days to 21 days, maybe even less, actually 20 days, 21 is the mean, so a few patients are just staying for the 10 days also. Re-exploration, initially almost every patient required re-exploration, but now you can see that in the 21 to 24 is just 1 patient out of the 3 patients out of 32 patients. Graft pancreectomy, if graft is not working, then you have to remove the pancreas also because of infection. So only 1 out of 32 in last 5 years. Insulin independence, 97%. No, not requiring the 30-day mortality. In last 1 year is 3.1%. So it is, I think, patient those are having the CKD, SPK is one of the best, but it is very difficult to get the organs. And for that, probably we have to be more aware, more contribute for this organ donation. And that is the common for this one. And this is one of our patient. You see the quality of life as well as his facial features. He improved, like it is not in the initial picture is looking like plethoric, his hair is like that, and now it is absolutely fine. Completed 10 years of this transplant, and indeed he was employed in our department on that basis, and is working with us as a educator for the diabetes patients. And this is another patient. So post-transplant, she conceived, delivered a healthy baby and doing fine. So actually did the miracle for these type 1 diabetes patients, and the cost for this is 2.5 lakhs at presentation. The duration of service is 6 to 8 hours. So is there. So future of pancreas transplant should be encourage the multiple centers, and the most of the people are surgeons are imported surgeons, not from all, they are learning, but at least at our center now we are happy that the rate of the complications is very less and patients are doing fine. Thank you very much for these patients listening.